I can see you. Dr. Harshul? Dr. Harshul is not here. Nilesh is here. Dr. Santosh Kumar Mahapatra, I saw him, yes. Dr. Shalabh Sinha? Dr. Shalabh Sinha? Not here. Dr. Ashish Majumdar? Not here. Dr. Nagendra Prasad? Ashish है? अच्छा ठीक है. Nagendra Prasad, Dr. Nagendra Prasad, not here. Deepthi is here. Dr. Vijay Sharma, not there. Dr. Parag Mukhopadhyay, hi sir. Dr. John Sarkar, awesome, all right. So, well, we have Dr. Parikshit here, and it's going to be a very fun session, and I'm sure that all of you are aware that it's a 2 minutes presentation. So, dot on time, don't lose your marks. Right, so we judges are strict, but nice. All right, yeah. So, Deepthi has requested to go first because she has a presentation. You also have a presentation? All right. So, Deepthi, let him go first because he's in the order, to be fair. And then Deepthi goes, yeah. Can we have the judging sheet for Dr. Parikshit and me? Right. The judging sheet, please. So, please take up the dice. And I request the audiovisual to keep a strict time management of 2 minutes. Dr. Parikshit gets in. No. There is a...
To augmented reality simulative training in 4 dimensions. You can see here our toolkit where the trainee who's undergoing training is moving his hands, which is actually coded in the metaverse. Now he is actually expanding the eyeball and he's having the MIGS Generation 1 eye stent in his hand, in the right hand, and he's placing the stent into the angle. When correctly placed, a green light is shown in the bigger model, which shows he's in the right orientation for hand-eye coordination development, so that it gives him a good feel of the 3-dimensional space when doing the surgery in real time. This is a patent protected technology of ours, which can also be used in 4-dimensional diagnostics, the angle structures of the patient and the fundus in real time images. With confocal fundus images, as you can see here, a splinter hemorrhage. On the right hand side, the observer seems to be moving through thin air, but he's actually examining an RNFL defect here. So this is the workflow. For example, a diabetic patient walks in, the fundus and OCT is done, then the data enters into the hospital database, our software intercepts it and converts it into holograms in 60 seconds. Thus, you can see in this patient not only a single slice of fundus, but also multiple slices of the OCT can be chosen and the patient can be counseled. This is also useful in 4D telemedicine, 4D artificial intelligence, multimodal retinal images, examination, along with low vision rehabilitation counseling, and the complex neuroanatomy pedagogy, as you can see here, with subtractive learning is very much possible, and all the structures in 4 dimensions can be appreciated along with simulative fundus examination. This, my dear friends, is the future of ophthalmology. Thank you.
Thank you so much. Do we have a quick question from the panelists, Dr. Parikshit or Dr. Somshila?
So this is a simulator that we are trying to develop with hand-eye coordination in 3-dimensional space. It's a cost-effective simulator, one. Second USP is we are using real-time high-resolution fundus images, angle images, OCT filters, which has never been done in any simulator because the models are not real. And we are bringing the element of hand-eye coordination into play. And with that, it's a very cost-effective simulator. It's available in Android, Apple, as well as in the headset that we have innovated, which is available on Windows, Tab. Simple phone, you can keep it a stand and then you can practice a surgery, which is very cost effective. Sir, in the smartphone it costs nothing, sir. The app is free of cost. It's named IMG AR in Android and IMG Max for Apple. If it is for the Microsoft platform, then it the app is there, it's free. The headset costs around 50,000.
This one?
Yes, sir. Compared to the other one available in the market, it's cheaper. If Jio comes with a much cheaper product, our app is a free of cost app, sir. Yeah.
Then
Yes, thank you, sir.
Thank you.
Yeah.
Okay, and play.
Thank you so much. So we go on to the next presentation. I call upon Dr. Deepti Joshi. I would request Dr. Nilesh to be ready in the other podium. So let's do it like quick, the next presenter can be ready. Over to you, Dr. Deepti. 2 minutes. The timer's on.
Hello, everyone.
2 minutes timer's on.
Presenting
Yeah.
a 6-year-old female child with large angle esotropia. Parents denying surgery, but finally said, "Doc, just give a shot, but make my daughter straight." 3 muscle surgery was dicey owing to consecutive exotropia. So we needed a fresh idea which was effective, safe, yet affordable. That struck the bulb. Botulinum toxin injection is a well-documented treatment in esotropia secondary to 6th nerve palsy. So why not use it in infantile esotropia? Post bilateral medial rectus resection of 6 mm, we injected 2 to 3 units of botulinum toxin into the belly of bilateral medial rectus muscle. This was done under direct visualization. You want to know the results? There was a mild ptosis and exotropia for 2 post-operative weeks. But on 4th post-operative week, the child was perfect orthotropia. So was this a one-time miracle? No, we have had consistent results in all children with large angle esotropia with just 2 muscles. So we bend it like Beckham with a corner shot of botulinum toxin.
Thank you.
Thank you so much, Dr. Deepti. Any questions from
Hello,
the panelists?
everyone.
The outcome in these children.
No, with respect, in the squint, the botulinum toxin is, in that 3 months when it is acting inside the eye, it is known to cause some permanent changes within that of the muscle fiber, which in turn results in a permanent change of the squint. So that is where we use it in paralytic strabismus also, where it causes the medial rectus relaxation, especially in case of 6th nerve palsy, and it makes the patient permanently straight. Similarly here, in the same way in case of infantile esotropia, see, this was a large angle esotropia, 85 prism diopter, just doing 2 muscle, I would have had residual, but if I had touched 3rd muscle, there was a chance that this child could have become a consecutive exotropia later. So to strike the balance, 1 single dose of botulinum toxin with the recession actually causes a permanent changes in some fibers of the medial rectus, and that results in these child have actually followed up for a period of 4 to 5 months, have gone in for publication also. It does produce a good result, but the only one cliche point is amblyopia has to be treated. Otherwise, that mild exotropia can become a consecutive exotropia later.
What is the permanent change that it causes in the muscle?
It results in the permanent lengthening of the muscle fibers, because of which it results in the weakness effect which is produced later.
Along with the adjuvant
Yes,
surgery.
exactly.
Okay, great, yeah.
But you do it under a short anesthesia, ma'am?
This is with the surgery, sir. I am doing medial rectus recession.
Okay.
In addition to that, I am getting. But if I have tried only botulinum toxin, recurrent injections are needed, sir. But if I am augmenting with the surgery, single shot, the child becomes perfectly straight.
Instead of doing reset, you will do only recess
With the botulinum toxin augmentation.
Wow.
Thank you, sir.
Yeah. Thank you, Deepti. Yes. So can we call upon our next speaker, Dr. Santosh Kumar Mahapatra? Yeah. Oh, sorry, Nilesh. Nilesh is here, so you can come here, right? Yeah. So Nilesh, over to you.
Thank you so much, ma'am. Thank you so much, AIO's Scientific Committee, for this opportunity. I'm going to present BX. I'll do explanation of BX1.
Why not?
The sound is not.
Okay, can we restart the timer, please? Timer आप बंद कीजिए. जब ये ready है, तब timer शुरू करेंगे.
सुनाई नहीं दे रहा है ना.
Timer restart, please. Can we restart the timer, please? 2 minutes. Okay, are you ready, Dr. Nilesh? Perfect, yeah.
Do you hydroimplant IOs while using BX1? Why not?
Most of us think, well, we need viscoelastics to explant the BX, then why hydroimplant the IOL? Hydroexplantation of BX ring is not as difficult as you think. Or is it? Let's see a few examples. Here under the continuous irrigation mode, we are going to hydroimplant a hydrophobic acrylic IOL. And just tucking the trailing haptic, we are going to hydroexplant the BX under the irrigating solution as well. So what we do is we go with the BX ring forceps, try to disengage the flange, try to disengage the BX ring in its entirety and leave it at just you see it starts spinning. So what you do, you stop your irrigation and just grab the BX ring from one of the vertices and by instinct if you press on the irrigation then it again starts spinning. So stop the irrigation and pull it out. But is it the ideal way? Let's try another way. Here we disengage the flange. We do not leave the flange at all. So we are preventing the spin, but still you see it's really traumatic because the other disengagement is not as good as it should be. So what we do next? So on the third try, what we do is we do a mix of both. We go from the main port, we try to disengage one of the flange. Let the other flanges be at its place. It's in the continuous irrigation mode, so you have a good chamber stability. Grab from one of the vertices and now try to disengage from all the flanges and just pull it out. It will be as simple as that. Thank you.
Thank you.
Thank you.
Dr. Parikshit.
It's multiple videos, so how many have you done together?
Sir, I have hydroexplantation of 5 BX ring I have done, sir. So these are the 3. It was a learning curve, but in the end, I got the
Measured
thing.
endothelial cell count before and after when it was done?
No, sir, we don't have the facility at our center, so couldn't do.
Excellent idea to remove it for those who find it difficult and are struggling while removing it. Actually, as you keep learning this technique of using the expansion device, it's not the removing that's difficult. I personally found the learning curve for insertion, for tucking all 3 very difficult initially.
Yeah.
So, but removal was never that much of a challenge.
The removal was a challenge for the toric IOLs, ma'am, because if we are just for removing the BX, if we have to inject the visco and then we get a rotation, it becomes difficult because there is a small pupil. So that's why we started hydroexplanting the BX.
All right.
So
excellent. Yeah.
thank you. Thank you, sir.
Thank you so much. Do we have Dr. Salab Sinha here? So if you can be ready with, yeah. All right. So we have the next presenter, Dr. Santosh Kumar Mahapatra. 2 minutes timer, and there you go, if you're ready.
Friends, I'm here to describe an innovative, no-cost suprachoroidal triamcinolone delivery system. For this, we took 22 gauge needle and broken it from its hub using a needle holder without much pressure. The tip is broken as well. A Castrovicius caliper is taken to measure the exact length of a 26 gauge needle from the needle hub till the beginning of the bevel. The same caliper is used to get the exact length from previously prepared 22 gauge needle shaft, which is put over the 26 gauge needle. Triamcinolone is drawn into the 1 cc syringe and the set of the needle thus prepared is fixed to the syringe for the injection after making it air-free and keeping exactly 0.1 ml of residual triamcinolone. After proper cleaning and draping, the exact measurement for intravitreal injection is taken as per the lens status, and the needle set is introduced into the suprachoroidal space, keeping the bevel up. The 22 gauge shaft behaves as a guard for further penetration of the needle, delivering the drug at suprachoroidal space. Following introduction of the bevel, The triamcinolone is simply injected and the injection site is sealed with a cotton tip application. Hence, I urge my fellow colleagues to try this simple but useful method of suprachoroidal drug delivery system. Hello friends, I am here to describe.
Thank you very much. Excellent, very innovative. Do we have any comments from the panelist and the judge?
It seems that I think it is going to make the safety of the injection much better because it's guarded and it's going to deliver in the correct space. That has been the challenge always. So either you're not in the correct space or it's not safe the way we deliver it. So it's a very simple and good idea. Really impressed.
So how many have you done so far?
We have a student who has done a thesis for already 50 plus injections.
But there are, how many?
Already in the process of publication in Nigeria.
Already found.
So what were the
Is there any side? Yeah, please. Yeah. Go ahead, Dr. Somshila.
Sorry, what were the complications that you encountered?
You can have subconjunctival hemorrhage with the commonest complication. Apart from that, IOP can be, but we have not come across any patient who has not been controlled after topical medications. And rarely you can have a penetration deep into, but as because you are putting a guard, there is very little chance that you will go inside.
So in your series, you had no complications due to the device?
Yes, device and method of, like when you are introducing, you have to be very careful, and we are keeping the bevel off to avoid any other complications. If you are keeping the bevel down, you may penetrate the glove if you are applying little more pressure, but here that is also taken care of.
Thank you.
Thank you so much. So we have our next presenter, Dr. Salab Sinha.
Okay, so
Timer on, yeah.
this patient came to me after 10 years of vitrectomy with a dense black cataract. Started off the rexus nucleus, but then you see what happens. The nucleus started to dip, and I thought let's convert to SICS, but then it wasn't as easy as I thought it would be. Very large nucleus, tried posterior levitation, tried to bring it into the anterior chamber. I thought I did, but then it started sinking in again. Again, going back with the needle and trying to pull it up. Still, one pole refused to come up, and finally it went down. So then I thought I will, take a needle and bring it up. And still, I couldn't bring it up. It was such a large nucleus with, in spite of the pupil being relatively, large. So then I thought that let me try something. So this is what I did, snared the large nucleus, made it into two halves, and you can see how big even that half is. And then, that was the main trick of snaring the black nucleus, and the rest is all routine, putting in your intrascleral fixation of the 3-piece intraocular lens. Removed all the iris hooks, removed the cannulas, sutured all the wounds, put in pilocarpine, and that's the end.
Excellent. Thank you for a wonderful presentation. Dr. Parikshit, you're the right
No,
person
I mean,
to...
a lovely surgery, without doubt. So what's the take-home message from this, sir? Other than the fact that you are a fantastic surgeon. You can do both anterior and posterior segment surgery.
No, I mean, I remembered the snare. So that was the trick, I remembered the snare because we use snare routinely in camps. We don't use it in our routine surgeries, but I always have 4 or 5 snares with me, and I regularly ETO it and make sure that it is available to me when I need it. And I needed it here because it was such a large nucleus, dense brown, wasn't coming. So I thought that I could do this. And because it was a vitrectomized eye, things were a little different. I wouldn't recommend anybody to do this in a normal vitreous. So this was a vitrectomized eye. I said in the very beginning, 10 years after vitrectomy he came with such a black cataract. I tried phaco, but then it dipped.
So what is the thing that you should have done preemptively?
No, I did not expect it to dip, because normally even in the dense brown cataracts, we know that they have weak zonules. So we have to be careful about the zonules. And I was thinking about CTR and maybe having to put a...
Won't a conventional ECC surgery or a large incision SICS, why even SIC, even ECC I would say, because then the cornea is completely safe as other zones.
Yes, very true. I could have done a SICS in this case as well. But unfortunately in my hands, whenever I've tried to do SICS with very dense brown cataracts, I've had the bag come along with the nucleus. So for me, doing phaco is easier than doing SICS in these dense brown cataracts.
I would only say that it's only a vitreoretinal surgeon who can do this kind of case, because whether it's falling behind or taking a snare and bringing it out, taking a needle, I think that it's not for the rest of us,
Yes.
normal mortals out here. The only critique I had is that what are the endothelial cell counts like?
Yeah, we don't have a specular microscope, but this patient had corneal edema for about a week, but recovered after a week.
You did what had to be done.
Yep.
Thank you so much.
Vitreoretinal surgeons like the nucleus better when it's posterior. Then they feel they have done something. Otherwise.
So do we have Dr. Ashish Majumdar? All right, yeah. So our next presenter is Dr. Ashish Majumdar, and I request Dr. Nagendra Prasad to be ready in the next podium so we can, quickly turn over, right.
Hello everyone, this is a case of 10 into 12 mm grade 2 limbal dermoid who was planned for manual DAG. First conjunctival peritomy was done. Then, with the help of 350 micron disposable microkeratom blade, a corneal incision is given. Then, with the help of crescent and Westcott corneal scissor, the dermoid is dissected out. After that, layer by layer, lamellar separation was performing with the help of crescent. But while doing this, suddenly intraoperative Descemet membrane perforation is noted, and my expression was, "Oh no." Then I thought, why not try something new? Then I grabbed my agar brush tool, which I used to debride epithelium, and I started polishing out the attached stroma from the pre-Descemet layer, and voila, it's getting clean. Then I put the donor cornea, put the first suture, and I cut out the excess flap which was given for the tamponade. Then the 16-10 monofilament nylon sutures was placed. Postoperative 6 months, vision improved from HMCF to FC 5 feet. Now question arises, why such technique? Because if perforation of Descemet membrane occurs, then anterior chamber collapses, which makes the further dissection difficult and increases the size of perforation. But diamond bar clears the stroma from pre-Descemet membrane without hampering the chamber dynamics, which results smooth pre-Descemet membrane, which leads to better result without double anterior chamber. Thank you.
Thank you.
But you know that the stromal polishing has already been described. It has with the burr.
Yes.
It has been published.
I have got only 2 cases like that. One paper with 2 cases.
That's right. So what I meant is that it's not new. So it has already been published. The technique has been described and has been presented at meetings. Unless you're the one who's published it.
No, I haven't yet.
Okay.
Dr. Parikshit, any question? No. All right, okay. So thank you for a good, excellent presentation. Now we go on to our next speaker, Dr. Nagendra Prasad. May I request Dr. Vijay Sharma to be ready on the other podium? Thank you.
Audio is not coming, just check it
Okay. Can we just stop the timer?
Audio.
Restart once he's ready, please. Thank you. Restart the timer, please.
Yeah, it's like that. क्या करें हम?
Very good afternoon to everyone.
Hold on. We'll just get your presentation on. Okay? Are you ready?
Yeah, I'm ready.
Perfect. Go ahead.
Very good afternoon to all of you. I will be discussing a small surgical video of modified Yamani technique. There's a patient of aphakia and the vitrectomy eye is there. So just make a inferior paracentesis to externalize the one of the leading haptics through that inferior paracentesis. This is a simple sutureless small incision intrascalar fixation of 3-piece IOL. So very simple technique. So I just put the AC maintainer, and after the IOL implantation, one of the haptics, that is the leading haptic, is externalized through the inferior paracentesis by using the maxillary forceps. Now the lagging haptic is first. So lagging haptic is externalized the 2.5 mm away and the 2.2 mm below from the limbus. The 26 needle is inserted. That is the oblique insertion. Now the lagging haptic has to be first externalized and docked the 26 needle, and they carefully externalized through that tunnel, and the haptic is cauterized by using the heated metal plate and just push it back in the tunnel. Similarly, another paracentesis is made. So another the leading haptic is docked through the 26 needle and it is externalized through the that tunnel. Now similarly the heated plate is used to cauterize and inserted back in the tunnel. So at the end of the surgery is a sutureless, a small incision. All the port is hydrated. It's a well-centered IOL at the end of surgery. So always use the AC maintainer. Lagging haptic used first, and the distance is 2.5 mm away. Make a long tunnel. Use a maxillary forceps. Thank you.
All right. Thank you for a good presentation, Dr. Parikshit.
Yeah, thank you, Dr. Sharma. So what's new, you would say, in this?
Sir, yes, a leading haptic is to externalize first. That is the modification in the Yamani technique.
Okay.
So if you externalize the leading haptic first, externalize the lead haptics first, so there is less chance of breakage of the haptics.
So it will make it more safer.
More safer, yes, sir.
Dr. Kudlu, you have any comment? All right, okay. So we'll go on to the next presenter, Dr. Nagendra Prasad. Are you ready? Still not ready. Okay. So we have Dr. Parag Mukhopadhyay.
Patient. Our aged patients who are alone or lesser number of caring people around them finds it difficult to instill eye drops in time. With self-effort, out of 3 drops, one falls on forehead, another on cheek, last one in eye. Even our flawless surgery may turn worse if drops are not properly applied. To instill eye drops, we have to bend our cervical spine to make face horizontal and someone puts it in eyes. While using mint top or minoxidil during my hair fall, I noticed it's tipped to be horizontal. Later, during COVID time, while I used Viroshield is a throat spray antivirus. It is having a smaller tubings and a smaller nozzle size and smaller aperture compared to Mintop. Eye drops are usually 10 ml, 5 ml container. If we reduce the diameter of tubings and make apertures further smaller, it will be a softer, economical, zero wastage, horizontal eye puff delivery system and make our patients independent. Thank you.
Thank you, sir. That was really innovative. Excellent. Yeah.
Very impressive to see this. My question is that, so does it come in a spray?
No, actually I used the 30 ml Viroshield, pouring water in it. So I had a great squeezing. But if it is turned to very smaller tubings and softer by the pharmaceuticals, and even my beloved brother, honored Dr. Devashish Bhattacharya, he is also doing some pharmaceutical works and researches. He also may take over to turn it to 5 ml and 10 ml container for those people who regularly use lubricants or glaucoma medications, and all the time the relatives can come forward and pour the costly medication in their eyes. Even sunglasses may be prepared with holes where they can softly puff it to target to the cornea, conjunctiva, etc.
Dear sir, the purpose of getting this spray sort of what you showed in your video, it is very good. But what is the indication just to prevent the neck to go for pain or?
No wastage. I have mentioned all the points.
Yeah.
Zero wastage, self-sufficient, singular person can use it, aged person can use it. All the points.
Okay.
Actually, one thing, men and horses ran, and gradually the wheel concept came. And this is a different concept. On this, in time, many development may be done to make it more economical than one eye drop even.
That is one, but my only concern is like the volume of a drop is about 10 to 15 microliter. How you will have to quantify and really regulate how much volume is being going in spray and how much you have to press. Because if you squeeze it more, the volume which goes out in a spray form will be much more. So that has to be there.
That is
Because
good.
in drop, if you press, it will come only one drop or
This is
multiple
a
drops.
concept, you see, and that
The concept is
the
good.
work of the people, like the wheel. When wheel was made, it was meant for Rath and bullock cart. But now the wheel is concept is for the aircraft and scooters and everything. So the research to reduce the expenditure, smaller FAP, it is the RD department, not mine. So people are there to make research.
So it's an initiative to a bigger research.
It's a very good initiative.
It's an initiative
No, it's
to a
a
bigger
wonderful
research.
idea.
Thank you so much, sir. Really appreciate. Right.
This is a case of phacotrabeculectomy, and while I'm making anterior capsule rhexis, I did not pay attention, I did not notice any wrinkling on the anterior capsule, and I completed the rhexis easily. That may be the sign of, why it is not coming. Yeah. While hydrodissection, I could see there is general dialysis. I tried to do the phaco even in this case without the help of any fixing devices. After repositioning, I started doing phaco while removing the last piece. I just noticed there is a large dialysis. I just stopped my phaco and injected viscoelastics from the side port. And it is very dangerous to remove phaco while the dialysis is there. Now I tried to hook the capsule, fix the capsule with the iris hook, and I managed to do with a little difficulty. I fixed the bag. Yeah. Now I implanted CTR in this case from the side port. To further stabilize the bag, and I injected IOL. I used IOL scaffolding technique for the removal of the nest of the nucleus, and I did it very well at the end. Thank you. So take home message is that always look for wrinkling or fold on the anterior capsule with while initiating CCC. Fix the capsular bag with hook as early as possible when not use the general dialysis. Don't remove phaco handpiece when dialysis noticed before injecting viscoelastic. If it is in the AC, do triamcinolone assisted anterior vitrectomy, though I did not had any vitreous prolapse in this case. Thank you again.
Thank you so much for the presentation. Dr. Parikshit, Dr. Kudlu, Dr. Somshil.
Thank you.
All right. Okay. So we have Dr. Harshul now for the next presentation. Yeah. Over to you.
Okay. Thank you so much. So I'll be presenting a very small innovation which I made for last 1 year and using this cannula. This is basically a hydro stitch cannula to hydro stitch the incisions at the end of the cataract surgery. We all know that many times most of us are doing under topical anesthesia and patient tries to roll eyes upward, and it's become very difficult to hydro stitch incision. So this cannula is made of 27 gauge. It has a band tip at the 85 degrees, and it's 22 millimeter in length, and it goes by my name. No financial interest in this. So this is how this cannula works. As you can see, at the end of the surgery, you just need to rotate your hands, turn the bevel to one to the other side, and you can very well hydro stitch all the walls. So when we use regular cannulas, usually what happens is the superior side or inferior side is difficult to attack on the right side of the incisions. It's difficult to change your hands and take the bigger cannula. But because it has only 1 millimeter length, it fits into the incision, as you can see here. You can very well just rotate your hands, and with rotation of your hand, you can easily hydro stitch all the incisions. And have a look at this case. Again, the same cannula. You can hydro stitch all the incision walls nicely. You can go and very well center the capsule, the IOL. And in the situation when you don't want your anterior chamber to collapse, like this situation where the capsular axis was torn, it's very easy to hydrostitch all the walls of the incision using this cannula. And it has another role also, that you can very well go ahead and do hydrodissection on both the sides. And after that, you can use the same cannula with the bevel down to rotate the nucleus nicely, as you can see here. So it not only serves as the purpose of the hydrostitch, but also you can use for hydrodissection. And this is how it in real external view, that you just need to change your hands to. And now many of our friends are using this cannula and find it very useful. Thank you very much.
Thank you. Any questions from the...
So is it now manufactured by?
Yeah, it's manufactured by Ovation International in Jaipur, and it's been exported also. I don't have any financial interest, but it's quite useful, especially where eyes is rolling up. You have very little space to, put the bigger cannula, which has normal length of, 3-4 millimeters at the end. Especially you can't turn your hands and hydrostitch all the walls.
Wonderful.
Yeah.
It cannot be rotated like this.
You just rotate your hands like this, it bevel changes, and you can do hydrodissection as I showed. You can rotate with bevel down, you can rotate at the same time. So it has that purpose also.
Length is just 1 millimeter.
Yeah, it's bent at 85 degrees and it's tapered at the end as I showed, and it gives a very good flow of.
Excellent, Harshal. I'm not a cataract surgeon, but when I used to do it in my PG, I'm sure every cataract surgeon finds it difficult with the closure, but you thought about it and you made something possible also, and now you're exporting it also.
Yes.
Great. Yeah. Thank you
so much.
Thank you so much. So do we have Dr. John Sarkar? Yeah. So we have the last presentation by Dr. John Sarkar. Over to you. Yeah.
Very good afternoon to all of you. I'll be presenting plan out of box. So it's a 2 minutes video, but it's a journey of more than 2 months, and is a toss of patience of both my patient and mine. So please enjoy the video. Sound please. Sound please.
Audio. Thank you.
Is a 45-year-old male complained to sudden drop of vision following molten metal injury while working in a factory. On clinical examination, left eye VCV 6/60 with conjunctival epithelial defect noted. Limbal ischemia involving 2 to 6 hours, near total corneal epithelial defects, and as a whole, it was grade 4 Duvers chemical. So our initial management was emergency tenor advancement and AMT on the same day. But in spite of the all trial, everything has well. Now the real game started. So what out of box we are planning? Making the zone of scleral ischemia, harvesting the CAG from the virgin part of the eye, host bed marking, SPG prepared from the cadaver eye with the help of our assistant who grabs the 4 corner, and it is the half thickness of the sclera, which is about 1 mm and 0.5 mm. Place it over the thinned out necrotic sclera, secured with fibrin glue. Additional sutures 7 biacrylic passes from the 4 corner. Our AMT was placed under whole ocular surface. It will act as a BM, basement membrane, for the newly reconstructed ocular surface. A CAG which already have harvested, placed at the limbus over the AMT. A allocate play from cadaver eye, placed at the inferior limbus, which acts as needles for the reconstructed ocular surface. Now it's become the reconstructed new ocular surface. My immediate post-op was uneventful, and the 6 weeks the patient was 6/9 N6, which has been maintained 6/6 N6 over the last 2 years follow-up. Thank you very much for patience hearing.
Excellent.
Thank you very much.
Dr. Somshila.
Yeah, ma'am.
And especially the outcome that you had in this case. But I think maybe you were a little lucky, or the patient was a little lucky, because the initial insult may not have been as much. So otherwise,
Initially, ma'am, on the same day when you came to us, that time actually the gesture was there. We have done the tenon advancement with the AMT. I thought it will be solved. But in spite of the aggressive management, it was progressive scleral ischemia noted. And we have done the ASOCT also. I think there's more than 50% scleral melt was there. So then actually we follow the, sir, what I want to mean that you have to follow, while you, being an ocular surface surgeon, you have to follow the grammar of the ocular surface. For which layer I am doing which thing. All it is not that until I am preparing. On the before the going with the surgery, I have in mind that for this layer I am doing these things. I draw the diagram, I go for that. That's why I'm going the excellent results.
I think a few small innovations that you showed of dissecting half thickness sclera.
Yeah, ma'am.
By having two assistants hold it for you.
Yeah, ma'am. Yeah, ma'am. It's very difficult. It's because so, otherwise run away.
So you have to keep your assistants also happy.
Yes, ma'am. Yes,
ma'am. Two assistants hold it for you. Only then you can go in the lab.
Yes, ma'am. Yes, ma'am. Otherwise,
very difficult.
It's very difficult, so and really it will from the dialing over that part, and right, other that related complications
that
will be there.
Your surgery.
Yeah, yeah.
One last question is that did you not think of the slit from the other eye?
No, ma'am. Actually, the thing is that if it is, all of us slit surgeon know the slit in the acute chemical management, it's still is a controversial. So better to preserve this eye for the future endeavor. If suppose this one is failed, then definitely I have something source in my hand. So it does for, and you can show it nicely how the cadaver eye from the donor, it's well proven, and I have done it also. So better to keep virgin the other eye. If successfully failed, then we can use it from the other eye, sound eye.
Excellent. I like your answers too.
Thank you very much, ma'am. Thank you very much.
Thank you. So we come to the end of the session, 2 minutes to win. And so we have the marks being tallied. All the presentations were excellent, and let's hope for the result. And we'll come up with a winner soon. Thank you so much. Thanks for all the audience and the delegates joining us.
And thank you for a very dedicated audience.
I hope this session was appreciated by all the audience. It's been a pleasure to run the session. I think that this is a very good format, and it was not gimmicky. We had a lot of true scientific presentations, a lot of science that went on here, and a lot of innovation. So congratulations to all the presenters.
Can we have all the presenters on the dais, please? We'll have a group picture, please.
Yeah, sir, of course. Switch camera.
Good evening. I think the next session is due. The topic is interesting.